This is session 153, and we are very lucky to have Dr. Mimi Hu from MD Anderson as our presenter today. She's on the faculty. She's been on the faculty since 2007. Sorry. And her clinical expertise is in the evaluation and treatment of patients with papillary, follicular, and medullary thyroid cancers, hereditary endocrine neoplasia disorders, and metabolic and bone and mineral disorders. She's the primary investigator and collaborator on multiple clinical trials evaluating various targeted therapies for advanced thyroid cancer. Dr. Hu has published articles and book chapters evaluating the management of medullary thyroid cancer, multiple endocrine neoplasia, bone health in cancer patients, endocrine complications of head and neck surgery, and perioneoplastic endocrine disorders. Dr. Hu is a ThyCa medical advisor, and we're very happy to have her with us. I want to talk to the Zoom group for just a moment and let you know that we are happy to have you here. And any questions you have, please type them in the Q&A, and Dr. Hu will answer them at the end when she is open for questions. Thank you. Dr. Hu?
All right. I hope everyone can hear me all right. Usually I speak very loudly. I'm getting a little feedback here. Let's try that. Is that better? Okay, yeah, that's good. Well, welcome to our beautiful, hot and humid Houston. We want you to get a true Texas experience, all right? Next time we have to talk to Gary about doing this in March. That's the best time in Houston, honestly. It is my pleasure to be here and to see all of familiar faces, even their dogs. I love that. But it's really just my pleasure being here. Honestly, I think this is my first in-person ThyCa since the pandemic. Obviously, I was on the Zoom, and I think this is so much more meaningful and special. But I do appreciate those who can join us by Zoom, because this is a great way of providing access to those who can't travel. So I'm glad we could do this in a hybrid fashion. I will be having two talks today. This first one is kind of more of a general talk on what every patient and their caregiver should know about medullary thyroid cancer. Some of this might be very basic to you all. Some of this might be very new, even to some of the folks who have been dealing with their MTC journey for even more than 5 years. Sometimes I'm always impressed that people have not heard some of the things when they come to see me. So I did make this somewhat broad to address that. My second talk will be on all the various therapeutic options we have beyond surgery. Dr. Mark Zaferio, I know, is speaking on surgery, and there will be other speakers around the country who will be down here to speak on medullary thyroid cancer as well. So you'll get a really nice perspective from various people about MTC. These are my disclosures. You will note that I am the co-chair of a guidelines update for medullary thyroid carcinoma and systemic therapies. Because of my role in that, I have not for the last few years taken any honoraria from any pharmaceutical company. So please know that this is really unbiased and based on science. So what are some of the questions I hope to address today? And I don't like to speak with my back to my audience, so I'll be getting a little closer since my eyes are not that good at reading things. So we're really going to try to talk about some of these questions that I think is really relevant for those who are new to their MTC journey in the last 2 years. But hopefully for those who are not the newbies, there's some new information that you get from this as well. So we'll talk about what is MTC, what's the distinction between a germline mutation and a somatic mutation. I am not a geneticist, but I think I can explain this in a lay person's perspective. How do we assess extent of disease in our patients? What are some predictors of behavior of disease based on what we know so far? What treatments are considered early in the disease course? What do we need to consider other than therapies? And when do we need to consider other therapies? And can I take the weight loss medicine or the diabetes medicine that I hear about? Okay, I hear that a lot. So as I said, we'll talk about spectrum of therapies after this lecture. So I hope you guys stay on. In terms of thyroid cancer, there are various subtypes. The most common type really is papillary thyroid carcinoma, or a subgroup of this differentiated thyroid cancer. Differentiated thyroid cancer are basically cancers that come from the thyroid follicular cells. And so there's papillary, there's follicular, there's also oncocytic thyroid carcinoma, used to be called Hürthle cell, but now called oncocytic. And then medullary thyroid cancer comprises about 1 to 2% of all the subtypes of thyroid cancer. Anaplastic thyroid cancer, the most aggressive, is less than 2% estimated. When it comes to medullary thyroid cancer, it's a relatively young disease described in the literature. In 1969 was the first report of it, and it's relatively rare. In the United States, anywhere around 1,000 to 1,200 new cases diagnosed. And again, these are not cancers that arise from the follicular cells. They arise from these parafollicular cells, meaning they just happen to be next to the follicular cells. These cells called C cells. And you'll notice throughout the talk that I have things highlighted in green. That's to give you a little definition in the bottom of the slide. So C cell stands for calcitonin producing, and these are little cells that are embryologically derived from the neural crest cell. So we do consider this a neuroendocrine tumor. There's no interaction functionally with the thyroid follicular cells. So we do not treat this like we would a differentiated thyroid cancer. We don't give TSH, levothyroxine to suppress the TSH. We don't give radioactive iodine to try to kill off these cells. Whenever we think about medullary thyroid carcinoma, the first thing that usually pops into our mind is, could this be a hereditary medullary thyroid cancer, part of a hereditary syndrome called a multiple endocrine neoplasia type 2A or 2B? Or is this sporadic, non-hereditary, meaning that did this come about after you were born? So when we think about hereditary, these are due to these germline mutations. So this is a mutation that arises that's in the germ cells. Germ cells are not bacteria or viruses. These are your eggs and your sperm. So these are mutations that might have been inherited from mom or dad. And Ms. Catherine Skeffis is going to be speaking on genetics of various thyroid cancers. And so I encourage you to attend that one if you can. And then sporadic is, or somatic mutation is when it's non-hereditary. I'm sorry, I'm standing in front of the screen here. But these sporadic is non-hereditary, and you can't pass it on to your children. And this just arose often than not, we don't know why, after you were born. When we do a very thorough interrogation of your own personal or your family history, looking for other hereditary components, anyone else with thyroid cancer, could it be medullary thyroid cancer, anyone else with hyperparathyroidism or calcium disorders leading to kidney stones, high calcium levels, anyone with any adrenal tumors, anyone with early onset hypertension or sudden death even because of hypertensive crisis. That's all probing for the other endocrine tumors that can be seen with the hereditary MEN2 syndrome, looking at hyperparathyroidism and pheochromocytoma. But even if we probe into that in your own personal history and family history, if we do a genetic test, about 1 to 7% might actually be found to be positive for that Rett germline mutation. So, and that could be because it's just not a very penetrant mutation. Maybe family members did not demonstrate their disease until older in life, or maybe they passed away from something else and was never brought to anyone's attention. Or it could be what we call a de novo mutation. De novo means that it's got to start somewhere. This was the first member in the family to have it. So it could be various reasons. So for that reason, every person who's diagnosed with medullary thyroid carcinoma should be tested for the Rett germline mutation, not only for potential family members to counsel them, but also we know that these mutations might predict what other tumors you might have if you do have this germline mutation, which I'll discuss later. So what is multiple endocrine neoplasia type 2? This is that hereditary syndrome associated with the germline or hereditary RET mutations. And this is an autosomal dominant. So going back to your biology classes from when you were in high school, basically you only need one mutation from mom or dad, and then it will occur in the offspring. And so this is a mutation, what we call an activating mutation of the RET proto-oncogene, and that leads to an abnormal RET tyrosine kinase receptor that's just always active, leading to cell survival and division and spread to other areas. The first association of the RET germline mutation with MEN2 really was recent, 1993. Really a young kind of association and understanding of this gene. MEN2A is the most common of the two subtype syndromes, and used to be called Sippel syndrome after a physician who kind of described this constellation of findings. And this comprises about 95% of the two MEN2 syndromes. MEN2B is the more rare of the two subtypes. Less than 5% of our hereditary patients have this. And actually, more often than not, it's due to a de novo mutation. Again, these patients will look very unique in how their gene express themselves, and yet their parents, when you test them, have no gene mutation. This is a cartoon showing you the differences between the two syndromes. I'm sorry if I'm blocking you all here. The only way I could see my slides over there, but I'll do it this way. So MEN2A on the left and MEN2B on the right. Basically, the common thing, of course, is medullary thyroid carcinoma. But then you'll see at the bottom are the pheochromocytoma. These are the tumors on the adrenal glands where it overexpresses metanephrines, and these are the patients who have that kind of syndromic situation of sudden onset of hypertension, headaches, palpitations, vision changes, they turn pale, and very, very anxious or panic attacks. Then the distinction between the two syndromes is that with MEN2A, the parathyroids are affected, and this leads to overactivity of the parathyroid glands, leading to high parathyroid hormone levels, stimulating the calcium in the blood to be high, putting people at risk for kidney stones, fractures, and abdominal complaints like constipation. And all of those glands would be affected because it's throughout the DNA. With the MEN2B, they don't have hyperparathyroidism. What they have are these very interesting neuromas on mucosal surfaces. So on the tongues, they'll have these very lumpy, bumpy tongues. Some of my patients have said, yeah, you know, when I was a kid, I kept biting on my tongue because of these nodules, and my dentist just recommended surgery, and they would just do resection and resection. And oh my gosh. So, you know, it's a shame that the rarity of this syndrome is such that people don't think about this when they see it. But it sometimes is the first people to notice this are the pediatricians or the dentists. These ganglion neuromas can also be in other mucosal surfaces, like in the eyelids. Patients will have these kind of everted eyelids, those turned out eyelids, puffy eyes. Their nose is a little more puffy because of the mucosal neuromas in their nasal passages. But also these patients can have these neuromas throughout their GI tract, and that could set them up for problems with severe constipation, not passing stools very well. And these patients are very sensitive to pain medications that have opioids, because opioids slow down the gut motility, and when they get on this, they get a really bad abdominal pain. So we actually recommend avoiding opiate-based pain medications in MEN2B patients. And these are just some findings that we can have with MEN2A, what we call variants. So Hirschsprung's disease is typically with RET mutations of 609, 611, 618, or 620 codon. So this is where I ask my patients, you know, do you know your specific RET mutation? Because it could kind of correlate with these other physical findings. But Hirschsprung's is, again, young, like babies showing up where their they're not eating well, they have failure to thrive, they're not passing stools properly, and they're at risk for having a small bowel obstruction and dilated loops of bowel. Cutaneous lichen amyloidosis is a very interesting clinical phenomenon that actually my mentor, Dr. Robert Gagel, actually looked at. This is in MEN2A patients who predominantly have a 634 RET mutation, although it has been described in a case of a V804 mutation patient. But it's amyloid deposition always between the shoulder blades of the upper back. This is not cancer cells, it's amyloid, it's a protein, and it causes their back to be very itchy, and the more you scratch, the itchier it gets. So we actually, best thing we recommend is don't scratch. It'll be this hyperpigmented area because of chronic years of scratching that region. MEN2B, again, this is where Dr. Gagel, when I was a fellow under him, he's like, these are the patients that you can spot from across the room because they have very typical phenotype. Phenotype is the expression of their gene mutation. But again, you could see here from left to right, puffier lips because of those mucosal neuromas, maybe a little bit more enlarged nose. Obviously, the one in the middle is the thyroid mass. But these are the little lumpy, bumpy things that we can see on the tongue surface. But you can also see on the lips, it's just kind of lumpy as well. Very interestingly, these patients don't make tears. They'll cry, they'll have emotional responses, they'll cry, but there's no tear production because of this abnormality. It's very unusual. And then our patients with MEN2B could have this kind of look where they're very long finger digits and very bendy. If they put their hands like this, I can only go this far, but they can go all the way down, past this kind of perpendicular line. Very long arms, and also they can, so it's what we call Marfanoid appearance, but they can have this kind of scooped out chest wall area. They can have very high arches on their feet, high arch palates, scoliosis, this thing called slip capital femoral epiphysis. And this X-ray or CAT scan on the right is very remarkable, showing those dark areas with the thin little lining. That's like the loops of bowel. That's how much air is distending in this person's abdomen. What does that RET receptor look like? So as I said, the RET gene that's mutated leads to this RET tyrosine kinase receptor to be overactive. So what you see on the left is just a cartoon of what the RET receptor looks like. It's just a single transmembrane receptor. The outside cadherin and cysteine domain allows for dimerization. And then once it's dimerized, meaning bound to another receptor, it leads to these intracellular tyrosine kinase portions to be autophosphorylated, and now it's going to be active. And when it's active, it's going to lead to cell proliferation, migration, differentiation, survival. In a normal setting, we all have RET in our bodies, and when RET is under the influence of GDNF and GFR alpha 1, it leads to that dimerization. But in MEN2A, the mutation typically affects the extracellular portion of that cell receptor, and now it's dimerized without the help of GDNF or GFR alpha. And with MEN2B, the mutations typically affect the intracellular portion. So now as a single receptor, it's just constitutively active. The 2015 ATA guidelines reclassified RET germline mutations into various pots or buckets of aggressiveness. And we have a mutation that is considered the highest risk, meaning highest risk for early presentation of their disease, highest risk for having lymph node or distant metastases, that's what DM stands for, and the highest disease-specific mortality, and that is the RET M918T mutation. Now, I'm sure that a lot of you all in the community here is like, wait a minute, I have that 918, but more likely than not, that's the sporadic or the somatic mutation, so non-hereditary. We're talking about germline. We're talking about if this was a hereditary one. And a lot of times this is more because that these patients start developing their medullary thyroid cancer at a young age. I mean, we we've had the youngest age of onset as a 2-month-old reported in the literature. So this cancer is developing even in utero, okay? And so these patients are living with their disease much longer before they probably have come to clinical attention. So unfortunately, disease probably has spread to other areas by the time they're clinically appreciated. So it's more, I think, just a time of presentation situation as maybe more so than just the fact that it's more aggressive. However, then we have high-risk mutations. So high-risk mutations are again, hereditary mutation of RET in the 634 codon, and then occasionally A883F, which is another rare codon mutation associated with MEN2B. These patients tend to develop their disease a little bit later than the MEN2B patients. High risk of lymph node metastases first reported in a 6-year-old as the youngest age, and so these patients, maybe even their teenage years, will come to attention. And then everything else is considered moderate risk. So if it's not a germline 918, not a germline 634, and A883, everything else is considered moderate risk. These patients tend to have maybe when they present, the thyroid cancer is still within their thyroid gland, maybe not yet gone to the lymph nodes. They tend to present later in life, maybe in their 30s or 40s or 50s or even 60s, and they present with lower calcitonin levels. And why do we care about the particular germline RET mutation? Because there is a correlation with how it's physically manifesting itself. So this is a graphic showing you that, for example, these 634 mutated RET mutated patients will have a very high, well, all of them have medullary thyroid cancer, but they have a high expression for pheochromocytoma, that adrenal tumor, and the highest risk for the hyperparathyroidism. But contrast that with a V804 mutated patient that very rarely associated with hyperparathyroidism or pheochromocytoma. And then you see the 609, 11, 18, and 20 patients with varying degrees of hyperparathyroidism or pheochromocytoma. But those are also the patients that tend to have that Hirschsprung's situation. So it does help us counsel our patients or be ready for other endocrinopathies, right, based upon their codon mutation. So here on the left, you see what I was talking about, the germline RET mutations, but what about the somatic mutations? So again, somatic means that it did not arise from an egg or a sperm that you would have inherited from mom or dad. So this is DNA alteration that happened after you were conceived. And when we look at the various mutations, the most common is a RET mutation in about 45% of these non-hereditary patients. Mutually exclusive mutations can be seen in RAS, RAS, more often HRAS followed by KRAS, and less often NRAS mutations. So when you take all comers with medullary thyroid cancer, the hereditary and the non-hereditary sporadic MTC patients, more than 60% of our MTC patients will harbor a RET mutation that was the driver of their disease. And I want to just put this out there because a lot of times I get referrals, patients come to see me and said, definitely doc, I don't have a RET mutation. I said, you mean hereditary, your DNA is negative. They're like, no, I had that tested, but also my tumor was tested and I don't have the RET mutation in my tumor. I said, well, let me see that report. And what I see is that oftentimes their oncologist or their other physician did what's called a FISH test or fluorescence in, so I have it right. Oh, I didn't write it in here. Fluorescence in situ hybridization. This is a way of checking for various mutations, but this FISH is only checking for RET fusions, not an activating mutation, a point activating mutation or a deletion. And so RET fusions are when the kinase portion of that RET gene, the coding region for that RET gene is fused to another partner that allows for activation. And this is what we see in papillary thyroid cancer, okay, a different type of cancer. It's seen in non-small cell lung cancer. So a lot of times oncologists, what they're seeing more often than not is lung cancer cancer, and they're thinking, okay, I gotta look for a RET alteration, so I'll do the FISH that I usually do for my lung cancer patients. And that being said, you might be thinking, oh yeah, it's negative, but that was not the right test. Okay, so then I've had plenty of patients who've come with me to me like this, and then I send their tumor off for next generation sequencing to check for really looking at that RET gene, and I do identify the mutations. So it really makes a big difference to the clinical care of our patients. All right, so how do our patients present? Often without any symptoms. It was just you had a car accident, you rolled into the ER and they did some CAT scans, and hey, by the way, you have a thyroid mass. Sometimes it's, oh, I went to a church a health screening fair and they were looking at my carotids, and oh, by the way, you have a thyroid mass, or some lymph node. A lot of times patients will say, I feel something. I've lost some weight and now my neck, I can see this thing in my neck. 30% of our patients can present with diarrhea. And this is mainly because the C cells coming from the neuroendocrine cells, they also make other peptides that leads to poor absorption of liquids from our gut and increasing motility of our gut. And so this leads to diarrhea, and it could be very profound. I've had patients who show up and it's like, I go to the bathroom every hour. I have 25 bowel movements a day. They can't keep their weight on because of the diarrhea. But it doesn't always correlate with the calcitonin levels, okay? I have patients, because a lot of people say, well, my calcitonin is causing this. It's not necessarily the calcitonin. It's these other peptides that are being co-secreted, because I've had patients with calcitonin levels 100,000, no diarrhea. And then someone with a 500, there's diarrhea. And so it doesn't always correlate with that. Flushing, because these cells also can produce these peptides that causes vasodilation. Your blood vessels start opening up a little bit and now you get flushed. Typically our patients will have this flushing with various triggers, either emotional triggers or alcohol, and basically those two are very common. Then Cushing's syndrome from ectopic ACTH or CRH production. So again, because of the neuroendocrine cell lineage, these cells can make these other hormones, ACTH or CRH, that then tells the adrenal glands to overproduce cortisol. And when you have too much cortisol, it leads to what we call Cushing's syndrome, and patients will notice that they're gaining weight, that they are losing muscle mass in their arms and legs. They're feeling very weak when they stand up. They have high blood pressure when they used to not have it. When they check their blood work, their potassium is low, and then also diabetes, high blood sugars. They have easy bruising. It's very profound. But luckily, Cushing syndrome doesn't happen often. Less than 1% of our patients with medullary will have this. These patients, when you evaluate and you suspect it, we check tumor markers, calcitonin, and CEA. CEA stands for carcinoembryonic antigen. So calcitonin is very sensitive. This is really the only cancer that makes calcitonin, but it's not very specific, because there can be other things that leads to calcitonin to be elevated, and I'll show you on another slide. But CEA is less specific. It can be made by other cancers or other areas in our body. It can be made by lung cancer, colon cancer, breast cancer, ovarian, and so it's less specific. So sometimes in my patients, if I see that all their lesions are very stable, calcitonin is not rising or calcitonin is low, but the CEA preferentially is going up, I will be recommending, let's screen for other things. In my women, I'll recommend, when was the last time you had a mammogram? In my men and women, colonoscopies, doing a vaginal exam, looking for those other potential sources of CEA. So calcitonin, there are a lot of vagaries with calcitonin, meaning it's highly variable. You go into the same lab, same day, 1 hour later, and you hadn't eaten, and yet calcitonin can be different by many points. Someone who has a 50 could come in next with a 60 or a 70. Someone with 1,000 could, 1 hour later be 2,000. There's just a lot of variability with calcitonin. CEA less variable. This is just an expected issue of the lab assay. There's just some inherent inaccuracy. Other things that drive up calcitonin, food. So so I always tell my patients to make sure that you're fasting at least 6, if not 8 hours prior to your blood draw for calcitonin. And if their labs are drawn late in the afternoon, you can have a light breakfast, but no bacon and eggs and hot cakes and all that kind of jazz. But a light breakfast and wait at least 6 hours before you get that blood work done. Iodinated contrast and CAT scans can also push up the calcitonin. I don't know why, it just does. But if you have a CAT scan without contrast, not a problem. If you have an MRI, not a problem. It's a different kind of contrast. But for some reason, the iodinated contrast. So I actually tell my patients that if you see your schedule and that your blood work is scheduled after your iodinated contrast CT, go to the lab first and then get your CT scan, okay? Even if you get your blood drawn within 30 minutes after the contrast, the calcitonin can be up. Also, I don't tell my patients to starve themselves before the 2 or 3 days before they come in to get lab testing, but 2 to 3 days beforehand, just be moderate in what you're eating. I've had patients who came to me from like a food and wine festival over the weekend, and they enjoyed themselves, okay? And I see that the calcitonin is like much higher, like 2,000 points higher than usual, and the imaging, everything is stable. And they happen to be in Houston a little bit longer, so a week later, I have them get it checked and it's come down. So basically, I had a patient who once like drank like 3 or 4 beers the night before the blood draw because the flight in was a hassle. So, just be cautious about overdoing the caloric intake the 2 to 3 days before you get your blood draw. But, if you always drink a glass of wine with dinner, sure, that's fine. But just, it's something that's more usual, not the unexpected. And again, we can't compare the calcitonin on one lab with another. Even if it's the same machine, the company that makes the machine, there's going to be different control specimens at each lab. You'll know that at various labs, there's quality assurance checks. And so there's always going to be a little bit of variability in that respect. And like I said, CEA does not tend to have as much of these issues, although there can be some variability. So if it's 8 one time, maybe it's 7.5 or 9 another time. How do we diagnose medullary thyroid cancer? Really, it's tissue is the issue, and we want to do a fine needle aspiration biopsy. That's what FNA stands for. Or sometimes you had a thyroid mass and they just went ahead and removed it, and then you find out that's medullary thyroid cancer. Now, sometimes we do have these FNAs that are inconclusive, or it's maybe suspicious for. And in that setting, sometimes you might want to think about doing an immunohistochemistry stain for calcitonin. But again, it's a little bit in the eyes of the beholder. Your pathologist sometime, or even just a staining technique may have been a little bit done a little bit differently. And so you may not see it as intensely expressing. And then you could do stains for CA and chromogranin as well. We look for the absence of thyroglobulin in a fine needle aspiration specimen. You can send off fluid off for a calcitonin washout. So there's these other ways of kind of confirming. But even so, sometimes it just happens that only until the surgical resection is done that the pathologist is able to really clarify. And medullary thyroid cancer can be confused with other tumors. So it's not always medullary thyroid cancer. So amyloid could look like colloid. So colloid is a normal proteinaceous fluid made by the follicular cells. So it could be a benign nodule. We can see these epithelial features under the microscope, and this might just be a follicular neoplasm or even a follicular-based carcinoma. Plasmacytoid features, maybe as a plasmacytoma. Spindle-shaped cells, maybe a sarcoma or even anaplastic. We have confused it with papillary thyroid cancer, paragangliomas, lymphomas. And then amyloid can be seen with other systemic disorders like amyloidosis or amyloid goiter or follicular lesions, like I said before. So it does get tricky sometimes. And sometimes pathology labs will send it off to another lab just for confirmation because maybe they don't see it as often. I get this question a lot. I had papillary thyroid cancer along with my medullary thyroid cancer or follicular thyroid cancer, and really not one predicted the other or one led to the other or vice versa. And we really believe this is just coincidental. Okay. And actually, there was a German study that looked at patients who had both medullary thyroid cancer and papillary thyroid cancer. And in the papillary thyroid cancer patients, over 1,000, there were 2.6% of them who also harbored medullary thyroid cancer. In the hereditary MTC patients, a smaller population, almost 160, 2.6% had papillary thyroid cancer. And then the non-hereditary MTC, about almost close to 500 patients, 4% had papillary thyroid cancer. So it's not really one led to the other. It's just kind of coincidental. And there's no data indicating that there's more aggressive behavior because you have that other tumor, okay? And if there is papillary thyroid cancer, if it's small, incidental, not a lot of lymph nodes involved, then low risk papillary thyroid cancer, you don't need radioactive iodine. But if you did have a burdensome amount of lymph nodes that did harbor papillary thyroid cancer, it might be reasonable to treat per standard of care with radioactive iodine. I am not going to go into surgery per se, but really for our patients with medullary thyroid cancer, it is the standard operation because honestly, the neck is a very small, confined area. And if there especially is a tumor that's already close to the trachea, or it's a large mass near the recurrent laryngeal nerves, or there's a burdensome amount of lymph nodes, we don't want these to continue to grow over time and lead to further problems with breathing or swallowing or voice changes. And so surgery really is the best option for those patients. And if it's still confined to the thyroid gland, it's the best option for cure, meaning that before it's gotten to other places like lymph nodes or elsewhere. And especially in our patients with MEN2 syndrome, if they've been identified because of a family member who was diagnosed and now they're getting genetic testing and someone's been identified to harbor the genetic mutation, then a prophylactic thyroidectomy might be potentially curative and they never have to manifest their disease with medullary thyroid cancer. We recommend ruling out pheochromocytoma prior to the surgery because the last thing you want is someone to have a hypertensive crisis on the operating table. And so either imaging or biochemical testing. We also consider waiting for that RET germline test before the surgeon goes in because if the patient has, say, a RET 634 germline mutation, they have a high risk for that hyperparathyroidism. So the surgeons really do need to know where those parathyroid glands are, where they left them, did they resect any of them? Because if the patient doesn't have hyperparathyroidism now, a 634 mutated patient eventually will. And so knowing where those parathyroid glands are is very helpful. And honestly, our germline RET testing comes back within a few weeks now. And so waiting a few weeks to have the right surgery and a well-informed surgery is worth the wait. Now, I always tell my patients that I'm always an eternal optimist, but I'm also a realist, which means that although we hope that we can get surgical cure even in those patients with already in the lymph nodes. There's when our patients have disease that is involving the lymph nodes, the chance of getting surgical cure is very low. And so there was a study that showed that in the patients who didn't have any lymph nodes involved at the time of their surgery, 38% will still have evidence of disease, meaning that 3 months, 6 months after that really good comprehensive surgery, their calcitonin can still be detectable. And unfortunately, that could just be that there's still microscopic cells and other lymph nodes that was not appreciable on the imaging. And thus, even in the hands of the best surgeon, there can still be microscopic residual disease. Now, those patients who have clinically appreciable lymph nodes at the time of their diagnosis, unfortunately, the cat already got out of the bag. And even with a very good comprehensive surgery, 90% of our patients will still have evidence of residual disease. So I expect calcitonin levels or CA levels to still be there after surgery. The surgery in that setting is, of course, hoping to get cured, but that's really not the reality. The reality is trying to control the disease so it doesn't cause harm down the road. Okay. Now, as I said, metastatic lesions in medullary thyroid cancer is actually quite common at the time of diagnosis because MTC is usually without symptoms, and people have had their disease probably 5 years, if not longer, before it clinically became appreciable. And so it had time to potentially spread to other areas without you even being aware of it. So the lymph nodes in the neck are the first place that it will go, what we call the central compartment. But then outside of that, 10 to 15% might have disease in their lungs, in their liver. In the liver, they look like these hypervascular lesions. Sometimes the CAT scan or MRIs will say hemangiomas. Hemangiomas are benign vascular collections in the liver. But whenever I see hemangiomas in a patient of mine with MTC who has a high calcitonin, I'm going to follow those quote unquote hemangiomas for a period of time, because if they grow over time and the calcitonin's going up or the CA is going up, now I have my suspicion confirmed that these were not the benign hemangiomas, likely metastatic disease. Bone can be seen in about 20% of the time, 25% at diagnosis. And luckily, brain metastases are rare. So we don't often just screen the brain with MRIs, but if we're suspicious of it, we will image the lungs and the liver and sometimes the bones. Unfortunately, even with good systemic options that we've had over the last decade or more, unfortunately, we don't have any options that can offer curative intent. That is the disappointing thing. But again, my optimism is that we've come a long way in the last 10 years or more. And at least we have more options now than we did when I started off as a fellow. How do we look for sites of disease? And this is the 2015 guidelines, and pretty much for the update that we're having, we're really updating some elements that has some relevance to patients who have distant disease that needs potentially systemic therapy. So we did look at imaging techniques as well, and pretty much our recommendations still stand, recommending ultrasound, CT of the neck, especially if we see pathologic lymph nodes on the ultrasound. This is because we want to look up high behind the jawline or down low behind the sternum, where the ultrasound may not appreciate disease. And this will help us understand the full extent of neck lymph node metastases. CT of the chest and imaging of the abdomen to look at the liver, either with CT or with MRI, and what we call axial skeleton MRI, looking at the spine, sometimes bone scan. This is usually when we see a calcitonin level over 500 and we're suspicious that when there's a higher likelihood of spread to other areas. Now, in the 2015 guidelines, FDG PET, which is the most common type of PET CT using radioactive glucose, F-DOPA PET, is not recommended for evaluating for distant metastases. I know that some patients do get that FDG PET because a lot of times that is the most common and most easily accessible PET to get. Now, if it's positive, it does indicate disease, and usually the FDG PET can be positive in patients with lymph node metastases, but it can be negative even in people with liver or bone metastases. And a lot of times that's because the MTC is a relatively indolent disease. It doesn't like that it doesn't need glucose to feed itself. So FDG PET may be falsely negative, even when we see metastatic disease to other areas. So that's why it's not recommended for routine detection. But in my practice, I do use certain kinds of PET CTs. At our institution, we have the gallium dotatate, but there's also fluoride FDG PET, F-DOPA PETs, and in certain situations, this might be very helpful. I tend to get the gallium dotatate PETs when my routine imaging, ultrasound, CT, or MRI is not showing much change, and yet I'm seeing tumor markers progress, and it's not attributable to just a lab issue, then I might get a gallium dotatate to look for other sites of disease. Gallium dotatate does seem to pick up bone metastases a little bit better than the other PETs. When patients have disease that has spread outside of the thyroid gland, that's when we see 10-year survival estimates go down. So if the disease is still confined to the thyroid gland, 10-year average median survival is more than 95%. If it's in the neck lymph nodes, that's what regional means, about 75% 10-year survival, meaning 75% living longer than 10 years, 25% maybe less than. Distant metastases at the time of diagnosis, the 10-year survival is 40%. This is just statistics though, okay? I have had plenty of patients, and let's do that, show of hands, who had distant metastases at diagnosis, who has beat this 10-year mark already. Congrats, yes, exactly, yes, applause there. That happens, and so I tell my patients, these are just statistics, you're not a statistic, and honestly, with our newer treatment modalities, good surgeries, radiation therapies, and others, and systemic therapies, I think our patients can live much longer than this. I've had a patient who was diagnosed with her MTC in early 90s, and she's had distant mets in her lungs and liver and bones for the last 25 years. And she's not on any systemic therapy. And I see her and she's like, can I see you in 2 years now? I'm like, no, I gotta see you in 18 months. No. Okay. Prognostic indicators. So certainly we can look at staging, but again, that's just statistics and it doesn't really help us very much. This was a very good study, I think, from a group of pathologists from various institutions, including some from the US. So 5 institutions where they look at the pathology of the thyroidectomy and lymph node dissection specimens. So over 300 individual patients' tumors were analyzed, and they looked at features that would describe it as high grade or low grade, okay? And high grade was if they found one of the following: a high mitotic index greater than 5 per high power field, a high Ki-67, this is just kind of looking at cell turnover over 5%, or tumor necrosis. And if you had any one of these 3, they considered this tumor to be a high-grade tumor. So it was just a 2-tiered finding, high grade or low grade. And what they found was that out of all these 300 and some specimens, the majority of them were low grade. 75% were low grade. And this is actually reflective of how our patients are. Most patients with medullary thyroid cancer have very indolent disease, but then 25% had high-grade features on that pathology. And the high-grade features were more often associated with male gender, a large primary tumor, so the tumor in the thyroid gland itself, a higher postoperative CEA. So after surgery, their CEA was still high, or they had distant metastases at presentation, or there was evidence of vascular invasion. Now, these graphs may be difficult for those who are on Zoom to look at, but I'll just kind of orient you. Going from left to right, the left slide is the overall survival. The second from that left side is disease-free survival. Then LRRFS is local regional recurrence-free survival. And then all the way on the right is distant metastatic-free survival. And the blue lines are the tumors that had low-grade features. The red lines are the high-grade features. I think even from the back of the room, you can see that the tumors that had low-grade features had much better long-term survival, overall survival, disease-free survival, local recurrence, regional-free survival, and distant metastatic-free survival. Those with the high-grade had a lower survival in each of these parameters. Now, I will say this, I think that this is still a relatively small study when you think about it, 300 some patients. You really do need pathologists who understand what they're looking for. I think that there is a room to further study this. In my experience, I don't know if tumor necrosis by itself is enough to really correlate with bad outcomes. I've seen patients with tumor necrosis and still very good survivals, but I do think mitotic index and Ki-67 does seem to correlate. How do we follow our patients after thyroidectomy? This is in this publication by our 2015 ATA guidelines. So you can print this off and get it from Thyroid. And so this is just kind of a flow diagram of how we follow our patients. But I will say what I do is after their total thyroidectomy, about 3 months after surgery, I check a calcitonin and CEA level. I'm trying to check for the nadir, or where it kind of bottoms out after the surgery. It is not worth checking calcitonin and CA every week after your surgery. Please don't do that, okay? That's just anxiety driving and you're gonna get really bruised up, all right? It takes time for calcitonin and CA to decline after surgery. And so 3 months is usually when I do that. It's a good time also. You could check thyroid hormone levels as well. And that gives me an opportunity to not miss potentially when I do see them at 6 months after surgery. Sometimes people do have aggressive disease that's even progressed since their surgery. So now I had that kind of 3-month nadir, so I know if the tumor markers at the 6-month mark is stable or progressing since that 3-month nadir. Another prognostic indicator is what we call this doubling time calculator. So the calcitonin and CA doubling times. This doubling time is not a straightforward calculation that you could do in your head. It's not like going from 10 to 20 to 40 to 80, okay? It is a very complicated logarithmic equation, and we actually have these doubling time calculators accessible on the ATA website online, and you just type in under the search doubling time and you'll get to that calculator. You do need at least 4 different values, typically spread out over a course of 2 years, to make this doubling time a little more interpretable and accurate. I have patients who get their levels done every month, and they have 4 levels in 4 months that they're showing me. I'm like, no, that's not going to be representative of what's going on. This is an exercise of patience to calculate the doubling time. But this is a meta-analysis that I still go back to because I think is very good. They looked at various studies that looked at doubling times. And to orient you, the graph on the left is the overall survival. The one on the right is recurrence-free survival. And the black lines are the patients who had doubling times that were long, over a year. And then the red lines are the ones who had doubling times less than a year. And so patients who had shorter doubling times, less than or equal to 1 year, had a lower 10-year survival compared with those who didn't, and a lower recurrence-free survival. CA doubling time might be a better predictor, mainly again because the calcitonin has this variability, so CA might be a better one. And then, like I said, this is just talking about how we calculate doubling times. It's very complicated. That's the website on how to do the doubling times. What do we do for some of our patients who have what we call the paraneoplastic syndrome, the diarrhea? With diarrhea seen in about 30%, this could be a very clinically problematic issue for our patients. We recommend dietary modifications. Do a stool diary. You actually track when you have your stools, what did you eat in the last 8 hours prior to that diarrhea episode. See what the triggers are, and then start kind of cutting things out to see if you can find those triggers. Oftentimes my patient says it's either dairy, it's alcohol, some say it's fatty foods, fried foods, sometimes it's gluten. It's different for everyone. We can treat these patients for their diarrhea with over-the-counter medications like Imodium, or you might need a prescription for Lomotil. Tincture of opium I've given. This is not going to be addictive, and it can really control it. Some patients are treated with octreotide. I said clay. I don't know if anyone's from Mississippi, but the Mississippi Basin has this special clay that actually is a good binder. And a colleague of mine actually ran this trial through our institution and made a big difference to a lot of patients' diarrhea. So maybe you go to Mississippi and do a little bit of clay digging in the basin, but it is not available to purchase. I do have a little stock in my office because the person who made it gave me some boxes of it. Um, when, when patients' tumor burdens are decreased, we also see resolution of the diarrhea. So some of my patients said, oh yeah, after my thyroid surgery, I had no more diarrhea. And they didn't realize that the diarrhea was always associated with their medullary thyroid cancer. But typically I find the diarrhea in those patients who have really burdensome disease in the liver. I don't know why it's predominantly liver metastases, but that seems to correlate more often with the diarrhea. Cushing's, ways of treating it are medical management like ketoconazole and metirapone to block the cortisol production from the adrenal glands. And then systemic therapy, we have our various chemotherapy drugs that actually could, by controlling the disease, will decrease the diarrhea. And in those patients who have that window of opportunity, bilateral adrenalectomy, we sometimes recommend, and then put them on replacement dose steroids afterward, because Cushing's is very, very dramatic for our patients. They get very sick and they're at risk for opportunistic infections, and sometimes they die mainly because of all those other complications and not necessarily from the medullary thyroid cancer. I'm going to discuss this at my next talk, so I'll kind of leave this for that next one for the sake of time. But we do things like focal therapy. So sometimes surgery, right, for recurrences in the neck, sometimes radiation, sometimes these drugs to target the bone metastases, and then sometimes targeting metastases in the liver. So to treat or not to treat, I am a Shakespeare buff. And so oftentimes this is the question, is like, when do we pull out that card for systemic therapy? And it takes we have to think very cautiously, because our drugs don't offer cure. And our drugs can convey side effects, even in this day of age of RET inhibitors, which are relatively well tolerated compared to the other drugs that we have. But there are some side effects that we have to keep an eye on. So we published this 10 years ago now, and we still adhere to this, which is if we see progressive disease radiologically, not just tumor markers. Okay, the tumor markers are not hurting our patients. The tumor markers might cause anxiety and they might cause mental harm, but they are not the things that are causing you harm. It's radiologically what are the tumors doing. So if they have significant progression, usually within 12 to 14 months, if it's indolent, something that was 1 centimeter 5 years ago, and now it's 1.3 centimeters 5 years later, that is not significant progression. And symptomatic and metastatic disease that's not treatable with any focal therapies or symptom support. And then bulky disease that's compromising nearby structures, that's not treatable with localized therapy. And this we'll talk about a little bit more with neoadjuvant as well. Now, this is for consideration in select cases. So maybe the doubling time is very aggressive, less than 6 months. We know eventually their disease is going to blossom, and there is structural disease, radiologic evidence of disease, but maybe that's not changing yet. But our concern is that maybe this is really a very aggressive disease that we're just not seeing at this moment. So it's just a consideration. And then severe paraneoplastic syndromes like the medullary thyroid cancer related diarrhea or Cushing's, that's not responding to traditional therapies. Okay, ending it out with, can I take this and this and this and this or this, okay? These are everywhere now. And this is the big question I get from my medis. It's a question I get from my papillary thyroid cancer patients. Everyone's asking me, endocrinologists ask me this. And so this comes from the preclinical studies where they tested these drugs in rats and mice. And they found that these rats and mice actually, when you give this GLP-1 receptor agonist, it actually led to C-cell hyperplasia. The C cells in the rats got plumper and the volume got increased and there were just more cells, okay? And actually medullary thyroid cancer developed as well. And what they found is that if you knocked out this, and when they looked at these rats and mice, there was a high expression of GLP-1 receptor on these rat thyroid glands. And when you genetically knocked out this receptor and they were exposed to these drugs, they did not develop C-cell hyperplasia. So it was really localized to these rats and mice having these receptors. And actually a very elegant study that was published over a decade now, they found that these receptor agonists, so all these drugs that I mentioned, they didn't activate the RET receptor nor these intracellular signaling cascades. So it didn't seem like these would lead to increased cancer progression in humans, okay? But these are just all preclinical studies. And when they tested these drugs in monkeys, which, you know, evolutionarily speaking is more in line with humans, there was no increase of calcitonin, no C-cell proliferation, no increase of C-cell volume or their thyroid weight. So I say we are not mice, okay? Mice and it's probably not translated towards humans. However, they did look at some various studies in humans. They do see that this receptor is expressed by medullary thyroid cancer cells and C-cell hyperplasia cells. People with Hashimoto's can get C-cell hyperplasia, but it's less expressed in patients with normal thyroid glands and papillary thyroid cancer cells. When they looked at various randomized controlled trials, so you know these drugs all have to go through big clinical trials in humans, they really found no statistically significant association with thyroid cancer. But in Europe, there's been these pharmaceutical or pharmacovigilance databases, and they found that out of 11,000 thyroid cancer cases, 236 of the patients had GLP-1 receptor agonist use. So still a very small amount. And then the French National Healthcare System thought that there was an increased risk of thyroid cancer and medullary thyroid cancer. But these types of studies are reporting biases, meaning if you had a patient with thyroid cancer and they happen to be on GLP-1 agonist, this is in the news, you're going to report that to the pharmacovigilance study or the healthcare system. So it might be a reporting bias. So in the end, don't really feel that there's enough data to say that these are associated with thyroid cancer. However, this is a black box warning on all of these drugs. You just insert name, okay, into those red boxes, and all of these have the black box warning that is not recommended if you have a history of medullary thyroid cancer or you have a history of multiple endocrine neoplasia type 2. And so for now, I don't recommend it for my patients with medullary thyroid cancer or MEN2. In my patients with non-medullary thyroid cancer, I don't mind them using it. And there's no standard recommendation to get a baseline ultrasound before you get started on therapy. But for you all in the audience, for now, I would say stay away from them and think about other ways to try to control diabetes or weight. So if you all have your phones, take a picture, not a picture, but get this QR code. Dr. Grubbs and I and Dr. Zaffario and others in our group had took years. We started this in 2018, 2019, even through the pandemic. We developed this education website, and this is intentionally not branded by by MD Anderson, because we wanted people to feel comfortable using this. This is a website that has lots of resources like common questions about medullary thyroid cancer, systemic therapy options, and everything. And I encourage you to fill out the survey. Tell us what you thought about this website. Did you like it? What would you like to see more of? If you, because that will help us improve this website going forward. And so I bring up these two books. Actually, one of my patients came in this week with the book. It was all dog-eared. There were like little stickers in it and everything. These books are very meaningful, and I appreciate all those who contributed to these two books. I actually give these books to my nurse practitioners and to my fellows when they graduate. I think it's humbling to know what our patients and their caregivers have to go through when they're diagnosed with medullary thyroid cancer. And it was very surprising to me where I read some things and didn't realize how something can be translated to the patient differently from what was the intention from the treating physician. And I think it helps us understand how we discuss things with our patients in a more informative manner without confusion. And then this is all my fellows who have done our Oncologic Endocrine Fellowship Program, and I'm glad they didn't drop me on the ground that day, but we are now celebrating our 11th year having an OncEndo Fellow in our program, and this is the only way to continue to further the field is by educating people to be able to treat this more effectively. So thank you all very much for your attention.
We have one online. Is M2V RET 883, is there research or study for her RET?
For her particular, okay, yeah.
Yeah.
Well, I will say,
So think it's undetectable.
yeah.
Where we-
Yeah, exactly. So, no, I think that similar to various other codon mutations, we're still trying to understand heterogeneity of disease. You know, even 634 or 918 patients, you gather them all together, they're going to have different expression of their disease. So, to be honest, 883 is not one of the more common codon mutations. So, it's hard for us to really put correlations together, but just continuing, I would recommend, if you've not considered it, is you could join our medullary thyroid cancer tumor registry if you're not already a member of it. But by continuing to, I'm not trying to be, mechanical about this, but by only having more patients involved in our registry, can we understand more about tumor heterogeneity, because this is a rare disease, and the more data we have, the better we understand it. So that's what I would say. Yeah. Okay.
So speaking of research, the codons that you mentioned, has any work been further done on the register that we hope people are still contributing to at MD Anderson of medullary cancer, and I guess not just MEN2A, but yeah, 2B, and then you added somatic too, did you not?
Yes.
Okay.
So our medullary thyroid cancer tumor registry now is a multi-institutional registry. It's not just MD Anderson. UCSF is involved, and we're looking at some other institutions to see if they want to join us. So again, just trying to increase access and data collection. But so it includes both non-hereditary and the hereditary medullary thyroid cancer with hereditary disease and even without. So it's not just RET mutated patients, okay? So we have RAS mutated patients. So actually from this registry, it has led to a lot of clinical studies, and we have published correlations of disease based on whether a patient had a RAS mutation versus a RET 918. Actually, Dr. Adi Shirali just published our experience looking at non-hereditary MTC who had RET 918 versus other RET non-hereditary mutations and even RAS mutations. Even now we're finding RET deletions and also, copy number variations. But that being said, the registry has been pivotal in helping us identify tumor heterogeneity. So yes, so please, it's worthwhile. I know it's yeah, thank you. Thank you. I'm so sorry. Myrtle. Yeah, yes, the K666. I'm So, yes, it's a lot of questionnaires. It's a lot of surveys. I appreciate everyone's time that they give to it. But please do. This is the best way for us to understand, because to be honest, I'll give you a great example. For the longest time, 918 non-hereditary RET mutation has always gotten this bad rep that this is the worst mutation that you can have. And I, in my small little world, I recognize that some of my patients with a RET 918 non-hereditary disease live longer than 10 years, longer than 15 years. Nothing is progressing. They're not on chemotherapy. And yet someone who doesn't have a RET 918 has a RAS mutation, or actually neither, much more aggressive, like things blossoming even within 2 years, right? But there's a lot of what I say call heterogeneity. So I always counsel my patient that 918 doesn't, in my experience, necessarily mean it's more aggressive disease. And we published this study by Dr. Shirali, and it proved that 918 mutated patients did not necessarily have worse outcomes than anyone else in the non-hereditary setting. So this registry has been very important to try to establish new paradigms for medullary thyroid cancer. Okay, so thank you.